Hi, and welcome to Chronically, formerly known as Concussion Talk Podcast. My name is Lauren Ziaks,
I'm Nick Mercer.
and we're teaming up to talk about all things chronic illness. We'll still be talking about chronic concussion, but we're going to follow a lot of other journeys along the way. So make sure to subscribe and check back in. Thank you so much for spending your time with us. Hello, and welcome back to Chronically, formerly known as Concussion Talk Podcast. I'm so excited to bring a new guest with us today. She's actually the host of Concussions in Women podcast. We're doing a special series, so make sure to check her out. This is Dr. Allyssa Memmini, an assistant professor of athletic training at University of New Mexico. Her research focuses on the development of post-concussion supports for university students returning to the classroom after concussion. Recently, her work has transitioned to university performing arts programs, where she collaborates with interprofessional healthcare teams and researchers to develop clinical guidelines to support a safe return to their performance environment after concussion. Thank you so much, Allyssa, for joining us. We're really excited to have you here.
Thank you. I'm excited to be here.
Well, let's get down to business. First, give us the background. Like, who are you? Tell us your story. Why are you so interested in concussion?
Yeah, totally. So I grew up in just north of Chicago. And shortly after high school, I went to the University of Wisconsin-Madison, where I earned my bachelor's degree in athletic training. And while I was there, I had the opportunity to be a research intern at Boston University with now Dr. Julie Stamm. At the time, she was a PhD student under Dr. Bob Stern. And it was an incredible experience. I'd be happy to share more about it throughout the interview. But that really kind of opened my eyes to concussions and really the long-term effects of repetitive head impacts. From there, after I graduated, I went to the University of Kentucky, where I was a graduate assistant athletic trainer for 2 years with men's and women's cross country and track and fields. I absolutely loved that experience and really building those relationships with my student athletes and the healthcare teams that were involved in providing a multitude of services for them was really one of the most special aspects about my job. But I knew that I felt like I could have those types of relationships maybe with students. And so I decided to pivot a little bit and go into academia. So after I graduated from Kentucky, I went to the University of Michigan, where I was a graduate research assistant at the Michigan Concussion Center under Dr. Stephen Berlio. So that's really where my work kind of started in developing return to learn supports. And now as an assistant professor of athletic training at the University of New Mexico, I've continued that work and continue building those strong relationships with my students and making sure that they are sound advocates for their own student athlete populations that they work with.
That's fascinating. You've really had quite the journey through the concussion who's who.
Yeah, very fortunate. Yes.
That's amazing. What did you think about kind of the evolution then? Because you've been in this space for quite some time, from your initial work all the way up through University of Michigan, how much the field has sort of changed. What's sort of your general perspective on that or takeaway?
Yeah, great question. So when I first was approached about the internship opportunity, that was around 2013. And that's where I feel like we really had a spike in concussion research, or really an emphasis in trying to understand the pathophysiology, diagnostics, and management. So I feel like I kind of got in at a really good time where I was able to really see the field expand so broadly. And then as I just stayed involved, whether that was through my own research or in my clinical practice, I've noticed that a lot of emphasis has really been put on movement as medicine. And I think that that's true beyond concussion in itself as well, but just really seeing the advancements in clinical care by incorporating physical activity really early on while patients are still symptomatic, I think has really improved our clinical care and of course our recovery outcomes. So that's been really special to see.
Yeah, I mean, that's really interesting. My brain injury was in 2014, but I was working in
Okay.
sports well before then. And so
Mm-hmm.
watching that evolution of go into a dark room, don't do anything. This is our special concussion room where the concussed
Right.
athlete goes, right? To this whole space of we don't want to push you too hard, but we also don't want to develop a fear of our symptoms or a fear of
Right.
movements. and really understanding how the autonomic system is involved, and that acute exercise intolerance, the treatment for that is actually symptom guided exercise to move people, to bring the fluids and to bring all the good chemicals to your brain to let it start to heal.
Yep, exactly. Spot on.
Well, I love your whole story. Tell me a little bit more about how concussion in women came to be, and what your goals are there.
Yeah, so I was approached by the founder, Nick Mercer, as you know, and he was connected with Dr. Steve Brolio. I think he had done a couple of podcasts previously, and I think Nick had the idea to really expand this work into female patients, which we know is a very underserved population in contemporary concussion literature, and then of course how we understand the clinical manifestations between males and females and so forth, and obviously recovery trajectories and things like that. So I've published a little bit of work with the CARE Consortium data looking into differences between males and females. That was led by Dr. Landon Lemke at VCU, outstanding researcher and friend. And so I've been really kind of exposed to those types of writing groups and learning from them. And I felt like I had a really nice network of individuals that I could reach out to really get the word out about concussions in women and how we can best support our female athletes.
Yeah, I mean, there was a new study that came out recently that it was a systematic review, I believe, where they were looking at how much research actually even includes women. And it was an abysmal less than 50%. I think it was by far less than 50%, but I don't want to give the wrong number. And so we just have so much work to do. And then, of course, the CARE Consortium is so important, but it's a very segmented portion of the population. And so we also need to look at the very reasons why we were excluded from research, right? Our hormones. How do our concussion experiences change across our lifetime, pre-pubertic and then going through our cycle, and then of course like postmenopausal. I mean, that would be incredible to be able to start to look at how things change as we get over the age of 40.
Absolutely. I actually just recently interviewed a PhD student, Emily McIndoe. She's at UVA, and her dissertation is really going to be focusing on how does the menstrual cycle influence concussion symptom profiles, but then also some of those recovery timelines too. So I'm really excited to learn more from her and other researchers who are interested in that space.
Yeah, that'll be a great. Make sure you check out that episode because that'll be really interesting to listen to.
Yeah.
And just for context for our listeners, the reason that women are excluded, first of all, of course, like a lot of the sports that they look at, the contact sports are predominantly male. So when we have this huge pile of research coming out of the consortium, which is again so important, we have to work to make sure that we have females included, right? But then also historically in research, women have been excluded because of the very things that make us different. So our hormones do affect the inclusion criteria and how people move through studies. And so we can't exclude us for that reason to have a clean study and then extrapolate male findings. We have to actually study the very thing that we're afraid of that makes us different. And then that's the only way we're really going to understand our bodies. And, we're 50% of the population. So I think we're pretty important.
Yeah, of course, absolutely. And I also just think that our wearable tech has also expanded quite a bit really in the past 10 years, but I just don't think we're where we need to be in terms of objective measures in really identifying where women are in the menstrual cycle, and that can obviously inhibit its use in research and of course clinical practice.
Yeah. Great points. So you've got this series coming on. How long will you think you'll be with us? Like, do you think you'll be with us for the long haul? Do you think it'll be kind of something short where people really need to tune in right away so they can get as much data as possible? What's kind of the process going to be?
Yeah, for now, it's going to be just a temporary series. I would definitely be interested in supporting other projects in the future. But for those of you who are listening that are interested in concussions in women, if there are certain topics that you are, wanting to learn more about, or certain individuals whose work is really speaking to you, I welcome you to reach out to me at any point, and I would be happy to continue that series moving forward as well. But for now, it's just a temporary kind of short stint.
Yeah, that makes perfect sense. I mean, we just said less than half the research even includes us, so we've got to get some more.
Exactly.
We got to get some more evidence to discuss too, right?
Yes.
Well, I know you're so into the performing arts right now, but if you don't mind, I want to pick up a little bit on the return to learn piece, and then
Mhm.
let's move into this really exciting space that you've moved your practice into. But can
Great.
you give us some of the highlights on return to learn? There have been protocols in the past. I know there's been some evolution. Can you talk a little bit about that and give the listeners some tips?
Yeah, absolutely. So we know that the four-step return to learn progression that was proposed by the International Concussion and Sport Group, that was really mirrored based off of the six-step progression from the return to sport strategy. So my understanding is that as they were kind of working through some of those guidelines, they felt really comfortable with the return to strategy progression, but felt like they needed a little bit more guidance on the return to learn side of things. And so they developed that four-step progression, beginning first with symptoms, low symptom activities of daily living, walking around, going to the grocery store, maybe some very, very light reading at home, no more than 30 minutes, things like that. And then as they progress through stages 2, 3, and 4, students should be gradually returning to more cognitive-based activities. So starting to transition into more homework, maybe at home, not necessarily at school, eventually transitioning into partial school attendance. And then by stage 4, again, it's going to be that full return to school without any supports. And during my dissertation work, as I was reviewing some of those protocols, I was thinking, this is really wonderful for our K through 12 students where we have direct oversight from a pediatrician, maybe a school nurse, if they're lucky and have an athletic trainer or two. Oftentimes they're going to be that point person to help them navigate those post-concussion academic supports. But as I was reviewing the literature, I felt as though it wasn't specific enough to the university setting. Particularly with our college students, we know that as they go up to college, they typically don't have that direct oversight unless they are participating in varsity intercollegiate sports, whereas the athletic trainer, team physician, there's a multitude of individuals that will kind of help them navigate that process, especially post-concussion. So as I was learning more about Return to Learn, I wanted to gain some insight into what our faculty and staff thought about how they have previously supported students after concussion. So one of my studies was interviewing both students and then also faculty and staff. Specifically at the University of Michigan, students had to have had a concussion during their time in their programs, and then faculty and staff, really the only inclusion criteria was that they had to have been a support or worked with a student who had the concussion. And what was really interesting was between the two groups, they felt like there was a really good dynamic between the two. Faculty and staff who interviewed were very positive and wanted to help the students. The students actually felt really supported, especially as they got into upper level classes, junior and senior level, where the cohort's a little bit smaller and they have a more of a one-on-one relationship with their instructor. However, both groups indicated that they really felt like they weren't exactly sure how to progress back to the class. So there was a lot of, we want to help you, I'm here to support you. Students reported faculty and staff felt very empathetic towards their situations, but there wasn't clear guidance on, okay, now what do I do that I have this concussion? How do I get back into my calculus class or biology, chemistry, things like that? And so we conducted a Delphi study, and those guidelines are now what we're terming the post-concussion collegiate return to learn protocol, and that was published in Sports Medicine in 2023.
Wow, I mean, that's the importance of qualitative research, right? Because what an incredible finding. We have this emotional
Exactly.
connection, but we actually have no idea what to do. We're just like all in it, winging it together and hoping for the
Hmm.
best kind of thing. So, what a great place to
Exactly.
then be able to create a guideline. And can you explain what a Delphi study is, just
Mhm.
briefly for people who don't know?
Yeah, absolutely. So Delphi study is very commonly used in when we develop clinical guidance, particularly on topics where there isn't a lot of research on. So at the time when I was doing my dissertation, there was very, very, very few studies on return to learn among collegiate student populations, particularly the non-athlete group. And so what I did was I basically created a list of concussion researchers varying in different ranks in terms of tenure versus adjunct, things like that. That in addition, there was also a group of clinicians, academic faculty, and staff. And really, they were all involved in creating some suggestions on how we could take the four-step progression of the return to learn protocol from the concussion and sport group and provide some additional guidance for a university student specifically. So they answered a series of open-ended questions. Once I received those, my research team and I went through and basically coded all of those statements and combined similar statements. I sent those back out to my group using a Qualtrics survey, and I asked them to grade all of those on a scale of importance. So how important do you think this is, with higher values indicating extremely important, lower values meaning very, very low importance, probably could be removed from the bunch. What's really unique about Delphi studies is that nobody on the panel of experts knows who is also involved. So the only person who knew who was enrolled was myself, which was really exciting. So as they went through and scored all of the statements, if any of the statements earned a certain score, they were removed from subsequent voting. And then I took the group overall scores and I sent the individual scores to each of my panelists to say, okay, here's how the group scored on this statement. Here's how you scored. Do you want to increase or decrease your score, or of course, keep it the same? So then I rescored all of those statements. And then that was the finality of the Delphi process, which resulted in the post-concussion collegiate return to learn protocol.
I mean, what an incredible process, right? So if you're listening, we have to gather a panel of experts, and then you have to go through this multi-step process with checks and balances and helping them see where things are being rated so that they get a chance to modify their rating based on where the group is going. They also don't know who each other are, so we don't have to worry about the kind of political or friendship groups going in there. So when there's not evidence to help support us, this huge process has to happen in order to give you the best possible guidance, right? And that's really important for people to understand, because it's great when we have the data, and sometimes that data doesn't generalize to other groups anyway, and sometimes there's not data. So we have to put all this work in to give you the best evidence or the best recommendations possible. So thank you for doing all of that work. That must have been quite the project. Corralling all of those cats, I'm sure, was not easy either.
Yes, definitely. But it was a really cool process. And it honestly, as I was kind of transitioning out of my PhD program, it was a really great way for me to network with other concussion clinicians and researchers in that space to develop additional networks beyond Michigan, which was really cool.
In clinical practice, the return to learn guidelines have been really important because, again, I've now been around long enough to have gray hair, right? And so early on, it was hard to get the schools to really understand, especially the high schools. Honestly, the colleges are a lot easier to work with in general. The high schools are a little bit more challenging. But when the return to learn guidelines came out and we could show a graph and we could start to make, basically we have a school accommodation form where I can just check boxes now, because now it's easy.
Right.
But it was really powerful for us to be able to go to the school and advocate for that high school athlete and be able to say, like, this is why we need to reduce the workload. Like, I understand there's standardized testing. I understand that school funding is tied to certain things. And this athlete isn't going to perform well anyway. So it's not going to help your funding. And also, we're going to prevent a kiddo from moving through the system and being able to go on about their life if we hold them back because of X amount of work. And so that work that y'all produced was really important clinically to help us be empowered to argue on behalf of our patients. So we really do appreciate that.
Yeah, of course. And I think something that's important to note is a lot of really the most recent research is suggesting that social involvement is really important post-concussion. We don't want our students or our athletes to stay in like a dark room by themselves and self-isolate. We really want them to engage in social activities. And so the quicker we can get them back into the classroom and at least engaging socially, the better the outcomes are. And I think a lot of times clinicians forget that the return to learn and return to sport strategies, those can be conducted in tandem. It's just that the student has to fully return to learn before they may be permitted to fully return to unrestricted sport participation.
Yeah. And that can be a hard one, especially for a 14-year-old to understand, right? So
Absolutely,
they still want to have their homework accommodations and they think they're going to play soccer. And so you have to have kind of a little chit chat with them. You know, it's not fair to ask your teacher to reduce your schoolwork by 50% and think you're going to go to soccer practice and play, right? Of course, it's also not good for their brain, but at 14, they don't care about that. You've got to talk to them in a different way.
Yes, right, right, exactly.
What about, I know this isn't really in your space, but as a clinician, there's so much evidence about return to learn and then now return to learn for college students,
Mhm.
but we really could also use some help in the return to work buckets. Is there
Mm,
anything that you know of that's sort of happening in that space? There was one recent systematic review that came out that looked at return to work, and I think it was the only one that there has been for chronic concussion. But that's
yeah,
definitely an area that we could really use help with in the
yes.
clinical realm.
Yeah, absolutely. I'm not familiar off the top of my head. I agree with you. It's very scarce, the literature that I am aware of. To be honest, I think it probably has to do with the fact that it's just a lot harder to track those populations in contrast to intercollegiate sports or high school sports, right? Where we know that the athletic trainer is going to be doing their documentation. Whereas in older adult populations, older meaning beyond college years, so not totally old, is it's really hard to track, especially those recovery trajectories, because if they don't follow up with their primary care provider or their neurologist or neuropsychologist, we don't necessarily know where they go afterwards. Um, Somewhat related, there is tremendous work out of the University of Georgia doing a lot of return to drive, which I think is exceptionally important, particularly post concussion and really any brain injury. And so that's been phenomenal work by Dr. Julianne Schmidt and Rob Linnall, and their whole team down there. So I'm hoping that within the next concussion consensus statement from the International Concussion and Sport Group, I'm hoping that they'll have some additional guidelines for us to consider as clinicians.
Yeah, wow, that would be very powerful because that's definitely always a challenging clinical conversation to have with a patient is,
Certainly, right.
are you allowed, are you not allowed? And it really puts you as a clinician in a dicey place to make a definitive decision one way or the
Right,
other. Yeah.
totally.
Yeah. Wow. Okay. Well, let's pivot to your work in performing arts. I'm very excited to hear about that. So can you sort of give us an overview of what that would even look like? And then we can kind of dig
Yeah.
in.
Yeah, absolutely. So when I was developing my return to learn guidelines during my dissertation process, I was connected to a physical therapist named Dr. Kristen Skyton, and she has become one of my co-collaborators on much of this work. I owe my career to her. She's wonderful. But so she was a part of that first Delphi study. And once it was wrapped, she reached out to me and said, Alyssa, this is really great work. But what about more movement-based classes, thinking about performing arts, and particularly the University of Michigan School of Music, Theater, and Dance? They have a multitude of different levels of students engaging in, playing instruments, singers, dance, other movements, and things like that. And so I thought to myself, oh man, you have a great point. But as I was reviewing the Return to Learn guidelines, I felt like those guidelines really didn't relate enough to the movement side of things. So we decided to look at the return to sport strategy to say, okay, how could we maybe incorporate some of these components into a return to performance protocol? So what we did in 2024 was we basically reconducted another Delphi study. This time we wanted to make sure that we included performing arts faculty and staff, specifically academic advisors, but also instructors. We also included concussion clinicians on university campuses. So whether they were a part of student health services or maybe an affiliated emergency department, physical therapy, athletic training, things like that. So that was wonderful. We also included a cohort of performing arts students or alumni who had sustained concussions during their training, because I felt it was important that their voices were also considered when we're developing some of those guidelines. And I felt like was a major limitation of my first return to learn study. Um, so basically, we did the same exact thing. I sent them a series of open-ended questions. I asked them to review those, provide some feedback. My research team and I went through, we coded all of them, sent them back out to the group. Anything that earned a score of, I believe, a 7 or lower was immediately removed from subsequent voting. And we basically used the return to sport strategy and created what we're calling the progressive return to performance protocol, which basically parses this out based on the student's discipline. So whether they are a dancer, a musician, or an actor. And there's specific strategies beginning with stage 1 all the way down to stage 6, or full return to performance without any supports in their learning environments, which has been really cool.
Wow, that's amazing. And that must have been a lot of work because the need of a musician is going to be very different than the need of a ballerina or a rockette
Exactly.
or whatever their specialty
Yeah.
might be. Yeah.
Exactly. And actually, before we even conducted that Delphi study, we conducted a systematic review just to see, what is the literature out there in terms of return to performance for our university specific cohorts. And what I'll say is that there really isn't much, unsurprisingly. Um, but especially when we look at the comparison between our intercollegiate athletes and our performing artists, when we think about the skill demands, they're actually pretty similar between the two. It's just that the NCAA oversees a lot of the rules and policies and procedures for our varsity student athletes, whereas with our performing arts groups, there really isn't any oversight in terms of how long they can practice or how many days per week. There's typically not a healthcare provider on site to triage patients, so it's really up to the instructor or their peers to identify a concussion. And unlike our varsity student athletes, our performing arts groups don't have annual concussion training. So they actually don't understand how to recognize or identify a concussion and probably are participating with concussion-like symptoms. And as we know, that can certainly prolong recovery or put them at risk for more severe injury.
I mean, that's really interesting too, that they're not even given any baseline education, right? Because I believe Dr. Broglio was saying a significant portion of the athletes who had injuries in the Care Consortium data actually had their
Mhm.
injuries, hanging out in the dorms, doing what college students do and things like
Of
that. And
course.
so, yes, probably, if you're a tap dancer, you're probably not getting a lot of concussions tap dancing, but they go out in the world and they get in cars and they slip and fall on the ice and everything else. And so
Totally.
it's this population where they should have this huge access, you would think, because
Mhm.
they're in this very controlled environment. And also, if they have the same level of education as the general population as terms of concussion, then these things might start
Mhm.
to get missed in a similar way that traditional students who aren't athletes might also have them be missed. So that's an
Mhm.
interesting group too, because you could sort of study some of that knowledge and belief system and have it at
Mhm.
least somewhat translate to more of the general student population, while
Right.
still having it be contained, right? Until you start educating them. And then, of course, you can't do
Yeah.
that anymore. But
Yeah, exactly. And really, the whole goal of both of the protocols, specific for our university students, is this is a way for you to initiate conversation with your instructor to say, this is where I think I am in this progression. These are some suggestions. It's not a mandated protocol you have to follow every single step. It's more so just a suggested progression that will allow the opportunity to collaborate between the student and the instructor on what would be most appropriate for their environment, knowing that the instructors are not educated on concussion and oftentimes really rely on personal experience in terms of how to best support students in the classroom. So um, and I will say too, a lot of people, when they think performing arts and concussion, I think their first thought goes right to dancers, of course, because they're moving, they're on elevated surface, there's partnering, there's props, there's so many other apparatuses that they need to be aware of, right? But we also see concussions with our backstage crew and our technicians, right? When we think about props maybe falling on them, it's very dim lighting, so it's hard to see, so tripping and falling is very prevalent. When we think about concussions with our musicians, our marching band athletes is a great example. So not only colliding with each other, but maybe colliding with a color guard's flag or a rifle that's getting tossed in the air, thinking about other props that could potentially get in their way. And when we have a concussion and you're blowing into an instrument that's almost mimicking that Valsalva maneuver, so it's going to increase intracranial pressure, intraocular pressure. And so those are some things that we wanted our clinicians to just start thinking about when they're having those discussions with their performing arts patients specifically.
well, that's such an interesting, I hate to admit that I never really thought about marching band or things like that before. Marching
Yeah.
band isn't huge here in Utah, at least where we live. So so I it's
Yeah.
just sort of ignorant to it. But I did plenty
Yeah.
of marching band in high school. That's really interesting to think about that Valsalva maneuver as well, and just the diaphragmatic breathing and breath control required to play an
Absolutely.
instrument or to sing.
Hmm.
We hear a lot in the dysautonomia space about getting back to singing
Hmm.
specifically, and
Hmm.
how the breath control changes with autonomic dysfunction or how
Right.
their symptoms can change. Patients with neurological disorders with vibration being a trigger. So, string athletes or string
Mm-hmm.
musicians actually can have
Hmm.
challenges with just plucking their own instrument and how that vibration changes in their body.
Wow.
And
Yeah,
what a big psychological impact that has, because for
absolutely.
musicians, I mean, I understand that for athletes too, it's a sense of their identity, but for musicians, so much so the way music touches your soul, it really
Hmm.
impacts them in a psychological way. So that's
Yeah,
very interesting and powerful work for sure.
thank you. Yeah, we're really excited about it, and we have more stuff coming, so more to come soon.
I love that. And I love having some strategies as well, and making sure people really understand the role of the autonomic system, and how
Hmm.
Valsalva changes, and the vestibular system for a dancer, right? If you don't know where
Absolutely.
you are in space, then you are in big trouble. If you're working in dim lighting behind the scenes, the poor forgotten people in the backstage, right?
Right,
And
right.
how unsafe we would think about like a worker's comp injury waiting to happen if they were out in the real world, right? And so
Yeah, totally.
yeah, these are also important. These are important places, and it touches so many people who are no longer athletes, but are living
Yeah,
in these other spaces in their real life. So
exactly.
thank you so much for this work.
Yeah, absolutely. We're so excited and happy to share updates as we roll them out. So we're really excited.
Well, before I let you go, are there any other places that you would like to see the field go, or evolutions
Mhm.
that you're really hoping for or looking forward to as this massive world of concussion continues to sort of roll that ball down the hill?
Yeah, I'm actually going to go back to a comment that you made before about qualitative work. I was first exposed to qualitative research during my PhD experience, and somebody with a very quantitative mind, like myself, I had a very hard time understanding the differences between the two, and how words could become data. And as I've really opened my mind and explored qualitative analysis, I've really come to appreciate the holistic experience that you can really get from a semi-structured interview. Um, I'm really hoping that, Concussion has done a great job with incorporating big data to identify long-term trends, like the CARE Consortium, the Limbic Matters group. There's tons of working groups that are working on that, and I think that is exceptionally important in this space. But I also think it's important to think about the individual experiences, because we know as clinicians, our management processes really depend on the individual symptom profiles, how many prior concussions they've had, and how long it's taken them to recover after every single one, which we know it typically takes longer. And then really targeting the rehabilitation to address those specific symptoms. So I'm hoping that we continue to really explore qualitative research and really understand not only the experiences of our student athletes, but really other underserved populations in regards to who is being involved in concussion research. We talked about performing artists. There are a number of other even athletic groups like Paralympics. I think we could really expand quite a bit further into in the qualitative space. I know Dr. Katie Mitchell did a little bit of work with qualitative analysis in that group, and I commend her for that work because I think it's really important. But again, I just really think that emphasizing the holistic patient experience is going to help us all moving forward rather than just thinking about a single data point.
I think that's really interesting that you say that. As you were talking, my mind started just kind of ADHDing around. Um, but when you talk about the qualitative piece and the thematic analysis, so
Mhm.
as you're coding your data and you're turning words into data points, there's this
Yeah,
saying in concussion, like when you've seen one concussion, you've seen one concussion, right? And
yeah,
and as a clinician, I have a little bit of a pushback on that, because yes, all people are different and they all have different backgrounds, but when you see enough concussions, people really kind of start to fit into buckets, right? And so
totally.
if we were to do some really great qualitative research on patient experience, you reach a saturation point, right? You reach a point
Mhm.
in and I'm not a qualitative researcher, so correct me where I'm wrong in this, but you reach a point where you hear the same thing enough times that is the
Exactly.
pattern, right?
Yep,
And
exactly.
so if you started to do some really robust qualitative studies on women over 40 or people in this
Exactly.
XYZ population, you could start to find where the weaknesses truly are. And
Mhm.
instead of it feeling like, well, everybody's so different, we can't do high quality research on these other populations, we
Mhm.
may actually find that they really aren't that different when you see enough of them in a
Mhm.
concentrated way. And maybe
Yeah,
that could help us tailor our quantitative, our more like intervene
exactly.
follow up studies in a different way, that maybe we could actually start to hit some of these gaps.
Totally, right? And I think too, I was at the last International Concussion and Sport Group meeting. They had a joint meeting with SNS in April of 25. That was in Milwaukee. And I wish I could remember who was speaking on this, but there was a clinician that was discussing individuals with persistent post-concussion symptoms. It's really important for us as clinicians to do a reevaluation of the cervical spine, because obviously there's a lot of mirroring between cervicogenetic symptoms and then also concussion symptoms. And maybe it's actually coming from cervical instability, potentially from the impact, or maybe they've just had it or developed it over time. And that targeting the cervical spine is going to be really critical. And it could maybe resolve some of those, what we think are concussion symptoms. So I agree with you that I think maybe grouping individuals either by symptom profiles or by specific cohorts will help guide clinical practice, especially when we think about those underserved populations.
Well, I mean, I could just tug at the thread on the sweater and ask you 500 more questions, but I know you are a very busy woman, and so we do have to let you go. But thank you so much for taking your time. Make sure you check out the episodes on concussions in women. Thank you for taking your time and listening to this episode of Chronically. Please keep coming back and let us know if there's topics you really want to hear about. We appreciate everyone being here. Thank you.
Thanks so much.
Oh, and where can they find you?
Oh, great. You can find me on LinkedIn. So my name is spelled Allyssa. Last name is Memmini. You're also welcome to send me an email if you have any questions or if you have any ideas or guests who would like to be featured on the Concussions in Women podcast. You can contact me at amemmini@unm.edu.
Thank you.
Thanks so much.